Let's talk about heart failure in the stable patient. We all know that anyone who's unstable with heart failure goes to emergency. But if you're someone in GP practice or in a healthcare setting that doesn't have emergency services and you found someone who's got a new diagnosis of heart failure, but they're very well, what do you do? Note this down. If there are no signs of fluid overload or shortness of breath or any respiratory distress, then it is safe for you to start heart failure medications. I always start with a beta blocker as long as their heart rate will tolerate it. Any heart rate below 60, I would not start a beta blocker. I usually start bisoprolol 1.25 milligrams once a day, and I titrate up over the next week or so up to a maximum of 10 milligrams once a day. Then I start either an ACE inhibitor or an ARB. Now, ramipril is usually the one that I go for. I start again at 1.25 milligrams once a day, but I have to check that their renal function is okay and their blood pressure will tolerate it. The same with an ARB. Their renal function must be fine. Then I start a eplerenone or spironolactone. I usually start at 12.5 milligrams once a day, and if they're tolerating that well, I move up to 25 milligrams once a day. Now, you're going to ask me about sacubitril valsartan or Entresto. Now, usually, this can be started in the community, but many GPs are apprehensive to start this without patients seeing a cardiologist first, and that's fine. Cardiologists usually initiate Entresto. However, if you're a GP and you're happy to start Entresto, then I would usually start with the smallest dose, 24 over 26 milligrams twice a day. These patients can have significant postural hypotension, so always ask them about dizziness. Now, when to start it? If the patient is already on ramipril, you need to have 48 hours of a washout period for the ramipril to completely be removed from their body before you start them on Entresto. If they are on an ARB, then you can start them directly from candesartan or losartan straight to Entresto. And lastly, starting an SGLT2 inhibitor. I usually start them on dapagliflozin at 10 milligrams once a day. However, if there's a concurrent infection, I hold off starting that until the infection is over. Or if they're prone to recurrent UTIs, then I don't start dapagliflozin because that can exacerbate UTIs. Once they're on all of those 4 pillars of heart failure medications, then they're adequately treated. Obviously, in the same time, I would refer them to cardiology, but there should be nothing stopping you from initiating heart failure medications, and you should do so slowly. There is no indication to start all 4 medications straight away. Do so slowly, making sure the renal function and blood pressure will tolerate it. Once patients are established on all of the medications, the next goal is to up-titrate them to the maximum tolerated dose, and you will do that over time. If you have any questions about heart failure therapy and initiating them, please pop them in the comments and I'll get back to you.